Blood remains a precious resource that has saved many lives. However, there is overwhelming evidence to suggest that the risk of transfusion outweigh the benefits in many clinical scenarios. Patient blood management is a multidisciplinary patient safety initiative that uses both medical and surgical methods to minimize the need for or even eliminate altogether the unnecessary use of blood and blood components. Patient blood management is not about practicing bloodless medicine. Rather, it's about giving patients every drop of blood that they need and not a drop that they do not. Some key concepts of patient blood management include using evidence-based guidelines in the decision to transfuse, using alternative strategies such as medications to treat anemia and bleeding, reducing peri-surgical blood loss by utilizing special equipment and surgical techniques, ensuring transfusion safety from pre-transfusion testing all the way through to blood administration, and ensuring timeliness and availability of blood components during life-threatening emergent situations.
Transfusions are not as safe as we thought. Stored allogenic blood is an imperfect substitute to the patient's own blood and leads to impaired oxygen delivery and increased patient risk. A comprehensive, evidence-based approach to blood utilization should therefore not be viewed as an option, but rather a necessity to ensure we are doing good and not doing harm to our patients. Blood is a living tissue, and when transfused should be thought of as a liquid transplant. Each unit represents exposure to a new donor and a new immunologic challenge. As such, each unit is a stepwise increase in serious complications. Over the past 20 years, there is clear evidence that a more conservative approach to transfusion practice is safe and is associated with decreased infection rates, cancer reoccurrence, mortality, and length of hospital stay.
As a major academic medical center, in an era of value-based care, we must adopt practices that improves quality and reduce cost. Blood transfusions are recognized by two leading healthcare organizations, the Joint Commission and the American Medical Association, as a procedure that is commonly used but not always indicated. A recent systematic review of approximately 500 studies published in this field over the last decade concluded that allogenic blood transfusions improved outcomes in only 11% of clinical scenarios for those patients without trauma or active bleeding. The Choosing Wisely campaign is a collaborative effort designed to spark conversations between patients and physicians regarding appropriate, evidence-based, and patient-specific treatment options. Multiple societies have identified blood transfusions in the top 5 commonly used procedures requiring careful consideration. Here is what those societies are saying about when to transfuse.
Our critical care societies support the idea of not transfusing red blood cells in hemodynamically stable, non-bleeding ICU patients with a hemoglobin concentration greater than 7 grams per deciliter.
The Society of Hospital Medicine recommends to avoid the transfusion of red blood cells for arbitrary hemoglobin or hematocrit thresholds and in the absence of symptoms of active cardiac disease, heart failure, or stroke.
Our society recommends that you don't transfuse packed red blood cells in a young, healthy patient without ongoing blood loss and a hemoglobin concentration greater than or equal to 6 grams per deciliter unless they're symptomatic or hemodynamically unstable.
The American Society of Hematology recommends not to transfuse more than the minimum number of red blood cell units, that is RBC units, necessary to relieve symptoms of anemia or to return a patient to a safe hemoglobin range, that is 7 to 8 grams per deciliter in stable non-cardiac inpatients.
There have been several studies that have indicated that there's an increased incidence of mortality, morbidity costs and the incidence of infection is increased when patients are exposed to transfused blood. This has motivated efforts on our part to decrease the exposure to blood transfusion, and in particular to treat preoperative anemia when present in an appropriate manner, which has included the use of intravenous iron and erythropoietin, and then also to optimize intraoperative hemostasis and return shed blood as much as we can to the patient using a small volume cell saver. We also use pharmacologic therapy, including antifibrinolytic therapy using epsilon aminocapoic acid or Amicar to decrease the tendency for bleeding after operation. And this has all contributed to our decrease in the use of transfused blood by about 50% since the initiation of this effort.
There is no doubt that blood transfusions can save lives, but they can also harm patients. For decades, we have overestimated the benefits and underestimated the risks. In clear absence of benefit, the patient is only exposed to potential risk and harm. Better transfusion practices are not only critical to improve safety and outcomes for our patients, but to reduce costs associated to non-clinically indicated transfusions. Thank you for all you do to help keep our patients safe.
UTMB Health, working together to work wonders.